He's addressing an important issue, and that is what to do with ovaries after chemotherapy. And all kinds of things have been tried in the past to prevent the damage from chemotherapy to ovaries. Some things work a little better, others worse, and the most recent one is the idea of stem cell treatment of ovaries. And that's the subject of today. Pleasure having you. It's all yours.
Well, thank you very much. It's really a pleasure to be here. It's such a nice audience and intimate gathering. What was fun about, at least for me, about being asked to give this talk is, I'm an oncologist, I'm not a fertility specialist, and so this meant I had to actually write a talk from scratch. I never give this talk. It's not one of my usual talks. But as was stated, I'm going to be talking about using adoptive cell therapies for treatment of chemotherapy-induced ovarian insufficiency. I do have some disclosures, although really none of these have anything to do with the topic. These are all related to my ovarian cancer work. And I do want to start off by really saying this isn't my talk I'm going to give. I'm giving a talk really for my colleague, my friend, my collaborator, Ray Anshin. Ray was an REI physician at the Brigham for about 20 years. He preceded me there by a few years. In fact, he was, I would say, a relatively new attending when I came to the Brigham as a resident. And we became friends through my training and as OBGYNs who were interested in science and research. And as I stayed on the faculty at Brigham Women's and opened up my own lab, Ray and I went from being friends and colleagues to scientific collaborators, and Ray became a wonderful mentor to me. So really the work I'm presenting today is really Ray's work. I'm going to talk about the genesis of his idea of using induced pluripotent stem cells for treating ovarian insufficiency, and then leading up to the work that he and I published together. This group is, I'm sure, well aware of this, but from an oncology perspective, it's interesting that women really bear the brunt of reproductive age cancers. And this is, we overall tend to think about cancer being more common in men than women, but that's actually not true if you look at reproductive age individuals. So about 1/10 of cancers in adults in their 20s to late 40s, or the cancers occur in that age group, but twice as many cancers are diagnosed in women than men. It's only after 55 that you see the rate of cancer in men start to skyrocket past that women. That's when we start to see colon cancers and lung cancers and prostate cancers. And if you're talking about where the lost reproductive years are, it's almost exclusively women. And this is an increasing problem because cancer incidence in young adults is increasing more than any other age group. So in the last 20 years, we've seen this go up at more than 20%. This is data from the UK, but it's very similar in the United States. And sticking with the UK data, what you see is that when you're talking about very young women, so prepubescent women or adolescents, it's predominantly hematologic malignancies, so the driving one, as well as things like brain tumors. But as you get into the core reproductive years, so 20s through 40s, breast cancer is certainly the most dominant disease. It's 43% of cancers in that age group. Now, risk factors for chemo-induced ovarian insufficiency, radiation is a big one. I'm not going to talk about radiation today because an irradiated ovary is a whole different problem. Hodgkin lymphoma, among the various malignancies, has the highest rate of ovarian insufficiency, and that has a lot to do with the chemo regimen that's used. The duration of therapy and dose certainly plays a risk, as well as the choice of agents. So particularly when we talk about alkylated chemotherapies, and I've highlighted cyclophosphamide because that's the backbone of chemotherapy for breast cancer. And so again, when we're talking about the reproductive age group, that's the one that's driving a lot of the ovarian insufficiency. Interestingly, diagnosis after puberty makes a big difference. So young girls who are treated with chemotherapy don't have nearly the degree of damage in the ovary as after the ovary has gone through menarche. And as I'll talk about, this is a problem that's compounded for women in their later reproductive years over 40. And we also know that women who have inherent germline DNA repair defects also have a bigger issue with ovarian insufficiency from chemo. So now the two are related. If someone's a BRCA1 carrier, she's more likely to be diagnosed with breast cancer in her 30s. And she's more likely to be diagnosed with the type of breast cancer that's going to require alkylating chemotherapy. However, because she has a DNA repair problem, the DNA damage that's induced by the chemotherapy, it increases the likelihood that she'll end up with ovarian insufficiency as well. So this is a compounded issue. And anecdotally, I'm sure many of you have seen that BRCA1 carriers in particular actually do tend to go into menopause earlier than when we don't have BRCA1 mutations. And there's debate about whether or not they respond more poorly to ovarian stimulation. I'd be curious to know what your collective experiences with that. But I will say anecdotally, I've certainly seen that, particularly for women who are closer to 40. BRCA1 carrier who's 40 going through an IVF cycle is much less likely to have a successful outcome. The regimen does matter, as well as age. So these are some of the more common breast cancer regimens that we tend to use. So AC is adriamycin and cyclophosphamide, and then CMF is one of the other more common regimens, which is cyclophosphamide, methotrexate, and 5-FU. But you can see what a difference age makes here, because if you have a woman who is 40 and receives a standard regimen of CMF, her risk of becoming amenorrheic is 80 to 90%. It's extremely, extremely high. Whereas if that same woman is, say, in her 30s, there's about a 1 in 3% chance that she develops amenorrhea. So it's not just the regimen, but also where a woman is in her reproductive lifespan. It makes a big difference as well. Now, this might seem obvious, but we don't entirely agree why chemotherapy is bad for ovaries. So there's two dominant theories for why chemo is gonatotoxic. And I'll get to the idea that there might be a third mechanism as well. So the first is the idea that chemotherapy is directly toxic to hormonal follicles. So certainly if you take a mouse and you administer alkylating chemotherapy agents, you'll see double-stranded DNA breaks in the oocytes themselves. This activates DNA repair pathways, ideally, but more commonly, the degree of DNA damage is going to lead to activation of ATM and apoptotic pathways like VAX and BAC, and those go down through the cytochrome C released from mitochondria, and you get apoptosis and follicular atresia. That's what generally happens. And as you can imagine, if you are someone who has an inherent DNA repair problem, like a BRCA1 mutation, it's even more likely that you're going to have apoptosis as the outcome. Now, the other hypothesis is what's known as accelerated activation, the burnout hypothesis. So this idea is that actually chemotherapy doesn't damage primary follicles. The thought is that what happens is it depletes the secondary follicles, but the loss of the secondary follicles leads to more activation of more primary follicles, and so you start speeding up the process of follicular development. And so the idea here is that as you deplete the resting pool, you eventually end up with a loss of primary follicles. And so the thought there is that it's this apoptosis of the growing follicles leads to a loss of the inhibitory signals, which would recruit other follicles from developing. So you get more primary follicle activation and this sort of burnout phenomenon. And so if you think about how GnRH agonists might theoretically work to prevent ovarian failure, this is really what you're trying to prevent. There's nothing about GnRH agonists which should prevent direct DNA damage. The only thing it can really do is prevent new follicles from being recruited and presumably becoming damaged. Now, the other thought about this hypothesis is is that with repetitive dosing, this is going to become a greater problem, right? Because you can imagine that every cycle of chemotherapy that someone goes through, you deplete another round of follicles, now you start to have more primordial follicles being activated. You hit them with another cycle of chemotherapy, and the cycle repeats itself. Okay, so this is just want to go over some experimental evidence. This is work from Amy Winship. Relatively simple set of experiments. They delivered dacarbazine, which is one of the drugs which is used in some hematologic malignancies and brain tumors. And they looked at ovaries from mice 2 weeks after administration. And just looking at the follicles very clearly, it's the primordial follicles that are dying off. You don't see changes in the levels of later follicle development. And this is quite similar to what you see in humans as well. So there's this very interesting paper where they took ovaries from age-matched women, very young women. So this is ovaries from two 22-year-old women. The arrows are pointing to various primordial follicles. This is a control woman's ovary, and this is a woman who's had CHOP chemotherapy. And you can see that there's primordial follicles go away. And if you look at different regimens, alkylating regimens, you'll see also primordial follicles. If you look at non-alkylating chemotherapies, you don't see that same phenomenon. Now, again, this is a process that's exacerbated by age. So in the same work by Amy Winship, she said, well, what happens if I take mice and I do aged mice instead of young mice? So mice also have age-related follicular atresia. So you can see that there are fewer follicles in the 6-month-old mice. But when you give alkaline chemotherapy to aged mice, you have even more rapid loss of primordial follicles. And again, looking at human data, if you look at sort of natural age-related follicular atresia, chemotherapy essentially accelerates this process. So if you look at that line, it just shifts downward after chemotherapy. Now, the reason I bring that up is that it's not a short-term problem. So this is data looking at childhood cancer survivors who received alkylating chemotherapy and what happens to them over the rest of their reproductive life. And so what you can see is that, yes, initially as they go through adolescence, their ovarian function appears to be normal, but they have this steep drop later on as they get into their 30s, well beyond what you would see in siblings not given chemotherapy. And so short-term studies, because many of the clinical studies are looking at 6-month outcomes, 1-year outcomes of amenorrhea. If you look at long-term outcomes, you get a much clearer picture about what the actual risk of ovarian insufficiency is. So this is looking at a group of adult cancer survivors in Ontario. This is about 20,000 women in this particular study. And what you can see is that it's not really a 1-year problem. It's a 1 to 3 to 5 year problem as far as when women actually get diagnosed with ovarian insufficiency. And so, for instance, the ovarian insufficiency rate among women with leukemia, so the average age of diagnosis for cancer in the study was 29, the POI rate was 21%, but usually it was happening about 2.5 years later. And even some cancers that we don't necessarily think of as having maybe a particularly high POI rate, we do see that there's at least some increased relative risk. Thinking about things like thyroid cancer, for instance. Now, this is a problem which gets magnified because there's two other phenomena to think about. The first is that just societally, maternal age at first birth is increasing. This is true actually across demographics in the United States. So whether you're talking about urban areas, small cities, or rural areas, age at first maternal birth is increasing. I couldn't find CDC data that was more updated than 2017, but I know it's across 28, at least in large metro areas. I think it's 31 in many large metro cities. And of course, your pregnancy rate per IVF cycle declines with age as well. So these are two trends which are working against the fact that now you're dealing with a shorter window. So if we're thinking that the average age of ovarian insufficiency for, say, a woman who's diagnosed with breast cancer in her early 30s, if she's going to develop POI, it's going to happen in her, let's say, 35, 36. She's already moving now to a point of falling off the curve as far as her likelihood of IVF success. And that's really the nidus for this, is that when we talk about options for fertility preservation, generally in the conversations that I have with cancer patients, it's embryo cryopreservation, oocyte cryopreservation, ovarian tissue cryopreservation. All three of those things require the ovary to be working at the time that the patient is presented for her consult. If the ovary is already has ovarian factor deficits, none of those three things are going to be helpful. Plus, obviously, any of these techniques requires time. So from an oncologic point of view, can the treatment be delayed? Requires funding and access. And there's no rescue option for an ovary which already has a defect. And importantly, none of this deals with the endocrine effects of ovarian insufficiency. So this is only talking about the fertility aspect of it. And one of the things that when Ray and I started doing this work together that Ray was very interested in was thinking about the other consequences of ovarian insufficiency. So accelerated aging and osteoporosis, premature cardiovascular disease, sexual dysfunction, all the effects of estrogen loss, even for women that might not be interested in fertility per se, the consequences of the endocrine consequences of, for many of these women, 20, 30 years of hormone replacement therapy is also something important to think. So the crux of this work then is how can we restore ovarian function? And when Ray initially launched these experiments in the sort of early to mid 2000s, there were three design requirements at that time, because this was just after a lot of the work in embryonic stem cells had come out. And there was certainly a governmental push to avoid embryonic stem cells. You also were looking for a therapy that was patient-specific, so ideally some sort of autologous therapy, as well as a lot of concerns about using xenografts. So the idea that if you were culturing cells using mouse cells or some other species as feeder cells, or using some sort of adoptive therapy of animal cells into humans, could you be at risk for zoonotic infections and issues like that? So as Ray was thinking about these sorts of problems, there was an explosion of papers which came out. So this is all these papers came out in 2008, 2009, really, in Science and Cell, looking at induced pluripotent stem cells. And so these are the Yamanaka factors, the idea that taking a somatic cell, and most of this original work was with fibroblasts, and then overexpressing these 4 transcription factors could reprogram a cell in such a way that it allowed development of all tissue types. So very exciting work, but these early efforts in induced pluripotent stem cells had some problems. The first was that if you look at these original papers, it's an extremely inefficient process. Some of these initial ones, the efficiency of actually reprogramming a cell was 1/1000th of a percent. It also very long derivation times. It took months and months to generate these cells in the lab. And it was very difficult to generate biocompatible feeder cells that allow you to sustain these cells in culture. So there was a lot of interest and enthusiasm about the idea, but it was very unclear how you could direct the differentiation of the cells, how you could make it an efficient process, and how you could make it theoretically safe. So at that time, another lab at Harvard came out with this paper, which caught Ray's eye, which was they were looking at using induced pluripotent stem cells for hematopoietic cells. And the key observation here was that if you took a cell which was earlier in differentiation, it was easier to reprogram than a cell which was terminally differentiated. And that might seem obvious, but it wasn't at the time. Here, what they were looking at, if you just compare these two dishes, looking at pro-B cells versus mature B cells. So as far as how many stem cell colonies you get, depending on what you started with. So they were able to increase the efficiency of generation by 300-fold. So now instead of getting 0.1% of cells being induced, they were now getting a third of cells. So it was a dramatic improvement. So this was the key insight for Ray in the way he wanted to take the work, because Ray's thought was, well, if it's earlier to reprogram cells, the earlier a cell is in differentiation, it's earlier to reprogram, why not use amniocytes? So why amniocytes? Well, they're readily accessible being amniocentesis. They're very primitive cells. They're essentially exfoliated embryonic cells, right? They're very easy to grow, and they proliferate very quickly. And Ray had a hypothesis that it would be easier to reprogram them because they're epigenetically more similar to an embryonic stem cell. So if you think about it, a cell is being exfoliated from an embryo, it's probably closer to embryonic stem cell than a adult somatic terminated cell. And so this was the first paper that that Ray really wrote on this topic, was the ability to use amniocytes as iPS cells as well as the feeder cells. So this is from that work. What Ray showed was that if you took either mouse or human amniocytes and you infected them with the Yamanaka factors, or in mice you actually only need 2 of the factors in order to reprogram them, you could get colonies of cells that could differentiate into all 3 layers and then the way that you test that in vivo is you inject them into a mouse, into the thigh of the mouse. It forms a teratoma. It forms a dermoid. You can see that you've got all 3 layers. And you don't see that if you look at the original amniocytes, or if you look at just fibroblasts from the mouse. So this was the initial observation. Now, in that same work, Ray also looked at gene expression, comparing human embryonic stem cells with these, what he called human amniocyte-derived induced pluripotent stem cells, so these HEDs. So looking just across the transcriptome, the correlation of these induced cells was very, very, very similar to embryonic stem cells in a way that you don't see between naturally occurring human amniocytes and human embryonic stem cells. And so it seemed like that there was, the reprogramming was almost complete. So we'll talk about it's almost complete, not quite. And so there was this idea that maybe what you could do is you could take amniocytes from an amniocentesis, you could collect these, you could culture them, you could use the amniocytes themselves as the feeder layer, or just grow them in a pool, differentiate them, and then you have a patient-specific therapy. You can imagine using amniocytes to repopulate tissues from basically a woman could serve as her own donor for stem cell-based therapies later on. But then that led to the question of, well, could iPSCs yield steroidogenic cells? So Shane, who was an REI fellow with Ray and me at the Brigham, looked into this during his fellowship. And the reason why Ray decided to focus specifically on steroidogenic cells is that when you grow induced pluripotent stem cells in culture, or just naturally embryonic stem cells, they form these aggregates called embryoid bodies. They spontaneously will do this in culture. And a certain fraction of these will make sex hormones. They'll make estradiol and progesterone. And what essentially happens is they recapitulate ovarian development. So if you look at these embryoid bodies, they look like natal ovaries, very, very early prepubertal ovaries. And over time, as you culture them in the dish, they sort of spontaneously will go through a maturation process, which looks like ovarian development. And so these embryo bodies that attach to the culture dish, they express ovarian markers like AMH receptor, FSH receptor, FOXL2, but then they also secrete high levels of estradiol. So Ray had observed that some of these embryo bodies stick to the dish and some of them float. The ones that float don't make estradiol. The ones that stick make estradiol. So for these is attached or suspended embryo bodies. But the problem was identifying which were the right embryo bodies that you wanted to culture, because it's a small percentage of the ones that are spontaneously undergoing this ovarian differentiation. So to look at that question, what we did was isolated neural granulosa cells from adult ovaries, and then from mice, and then compared these to postnatal day 2 ovaries, so very immature ovaries, and then looked at the gene expression between the adult neural granulosa cells, the postnatal day 2 ovaries, and then these embryo bodies. So essentially looking for a set of shared genes between the attached embryo bodies. So what were these ones that were making hormones and had ovarian factors that we wanted, and that were seen in these sort of very early ovaries, but not seen in adult granulosa cells. So essentially looking for a marker that you could use to select the embryo bodies that are going to be most suitable for making a steroidogenic induced pluripotent stem cell. And it turns out that it's AMHR2. That's what you're looking for. So what we found is that there's a very small percentage of cells that express AMHR2. If you sort those cells out by FACS, they're the ones that express high levels of FSH receptor, FOXL2, and they make higher levels of estradiol. And in the same paper, it was shown that you could do this with human cells as well. And not only did they make high levels of estradiol and express ovarian markers, but you could culture them for weeks in culture. Weeks and weeks and weeks and weeks, months in culture.
Do you need to provide exogenous androgen for them to make estrogen?
That's a good question. Yes, eventually. They need substrate, but you keep synthesizing it, yes. Yeah.
I assume you saw induction of aromatase.
Yes. So I didn't show the figure here, but in the same paper, they add aromatase inhibitors and show that hormone production goes away. They add testosterone, and hormone production goes up. So they did test the synthetic aspect, yes. Right. But you would have to continue as a source in the culture.
This is interesting because this receptor of the ovaries is most frequent in adrenal glands.
Okay.
And the adrenal glands have a common predecessor with ovaries. So I didn't know that. That's very interesting.
Now, Ray, question, again, this is a spontaneous process, right? So the question is, if it's a spontaneous process, why is it happening? And Ray thought, well, if there's an epigenetic memory, that's important. So maybe what you want to do is make your induced pluripotent stem cells from a tissue that's most similar to what you're ultimately trying to reprogram it into. Okay. So the thought was, if what you want to make at the end of the day is an induced pluripotent stem cell, and you want to induce that stem cell to become ovarian cortex, take a cell from the ovarian cortex, reprogram that into a stem cell, and then differentiate it. To turn that into your cell line, and then have a population. And so, and you probably know Zev, he's here in New York now, right? So Zev and Ray did this work together, looking at could you repeat this process, but instead of using amniocytes, use granulosa cells. And of course, amniocentesis is not done as frequently anymore as it once was, but IVF is still done quite a lot. And every time you do an IVF cycle, you get a huge amount of follicular fluid, and it's full of granulosa cells, right? So they had the idea, well, could you use the granulosa cells that were discarded from an IVF cycle? And the short answer is yes. So these are what we refer to as GRIPs, or granulosa cell-derived induced pluripotent stem cells. And so both in mice and in humans, they express, again, all of these Yamanaka factors once they're transfected. They differentiate in vitro and in vivo into serotomas. But what was different about granulosa cell-derived induced pluripotent stem cells from the amniocyte ones is that these preferentially make estradiol. They don't make progesterone. There's not very much of it. And if you took them, they would go through this sort of suspended embryonic body and then attached embryonic body. They will make preferential estradiol. They seem to retain some sort of epigenetic memory that makes them want to make estrogen-producing estradiol. So you've got a cell type which is doing two things simultaneously. It is still making estradiol, like a granulosa cell expected, but it also now the induced ovarian insufficiency in the mice. Can we restore ovarian function? That was really the crux of the work. So how to test that? So there were two sets of workflows. So this is the way these are generated in the lab. So collect granulosa cells, in this case from mice that have been stimulated, transduce them using them to knock down knockout factors to get these murine grips, granulosa cell-induced pluripotent stem cells. In order to be able to trace the lineage of the cells, we infected them with GFP, right? So that you knew that the green cells are the ones who have reprogrammed. And then take them through this embryoid body differentiation. This, again, the spontaneous process that will happen. So you let them form embryo bodies, you put them on gelatin-coated plates, they'll attach, and then use flow cytometry to sort out the ones which express the AMH receptor. So you want cells that are both GFP positive and express the AMH receptor, and then look at their steroidogenic capacity as well as their germ cell marker capacity. So that was the first set of experiments. And essentially, if you compare a normal mouse ovary versus what we see in these sorted embryoid bodies, we see the same markers that we see in a mature ovary. We will see in the oocytes, in these embryoid bodies that are derived from these granulosa cells. So we saw oocyte markers. The other thing which was interesting in this particular study, this sort of came out in the course of developmental work, was it turns out if you keep some of the follicular fluid in the culture, this works a lot better. So there's something about, it's not that different than using conditioned media, but if you take the follicular fluid and you add either 1% or 5% follicular fluid back into the culture, it dramatically increases the efficiency of the polarization. So you get
Mouse follicular fluid?
mouse follicular fluid. So human follicular fluid. Sorry, it's human follicular fluid added to mouse culture.
Okay.
Yeah, sorry. So whether it's human or mouse, you can do this with human and mouse cells, but it's human follicular fluid. So you get liters of human follicular fluid from IVF. So, so you get higher production of estradiol, as well as higher expression of the germ cell markers. So it's not just, okay, you're putting more substrate in, and so they're making more estradiol. You could sort of imagine that. But actually, you get a higher expression of these primordial germ cell markers. Now, this process, so then that was the in vitro part. So what about the in vivo side of it? So again, sorting out these cells, it's a very small population of cells, talking about 0.7% of a million cells. But if you take the unsorted cells, so you have the ones that you haven't picked out the AMH receptor positive, and you inject them into a mouse, they'll form a teratoma, right? That's how we showed the COVID. But if you take the sorted ones, they don't form a teratoma. Now, we didn't see anything. What was interesting is if you take the mice and you look at their hormone levels, they're making estrogen. So there's no teratoma, but you correct the endocrine defect in the mice. Okay.
Is this like you're just delivering the cell's IP or something?
In this case, it was we were injecting them. Well, we do inject them into the ovary of the mice.
Yeah.
But I was able to figure out which mice, just by looking at them, had received sorted cells or didn't, because, well, just on the tumor, when you give the mice chemo, we'll talk about in a second, the ones which end up with ovarian insufficiency, their mammary glands go away. Whereas I could tell you which mouse had received stem cells, which ones didn't, because I could see the mammary development of the mice.
Yeah.
So just picking them up, you can tell which ones are the controls.
Teratoma, was it just like a benign teratoma? Or?
Right, well, yeah, exactly, yeah. Because that's usually the way you would test for potency. But in this case, we actually don't see it, this word itself. Okay, so this is the crux of the in vivo experiment, was to take 8-week-old nude mice, gave them alkylating chemotherapy with cyclophosphamide busulfan, which is one dose is highly effective at inducing endocrine insufficiency in the mice. Then we would perform laparotomies of the mice, and into the ovary inject either just vehicle, the sorted cells, or the unsorted cells. So the unsorted ones would form these huge teratomas in the mice, and the mice would actually eventually die because they get these huge tumors. The control mice, we would see that they developed ovarian insufficiency. They made no detectable levels of estradiol. Sorted mice, though, well, we'll talk about that. So, as I said, we GFP labeled them so we could tease out where the cells ended up in the ovary, and this is what we found. So, if we injected these sorted induced ovarian stem cells into the ovary, we could see green oocytes. This is what I call the green eggs in mouse experiment. Right? So, very happy day in the lab to see a green egg come out of an ovary of a mouse. So we said we got GFP positive oocytes from ovaries which had been ablated with chemotherapy. Then we took those oocytes and were able to both activate them through parthenogenesis, but also to fertilize them with sperm in the lab to form zygotes. What was also interesting is that if you looked at the ovaries of the mice, we found GFP negative oocytes as well, surrounded by GFP positive granulosa cells. Meaning that what had happened was that some of the stem cells, when we put them into the mice, had gone down the steroidogenic differentiation pattern, but actually were now surrounding oocytes and seemingly rescuing them. So then the question was, okay, is it possible that granulosa cell loss is an unrecognized cause of chemotherapy-induced infertility? So maybe what happens is you kill off the granulosa cells, and so the oocyte dies. It's not that you kill the oocyte. But if you think about it, an oocyte develops in utero, right? So it lives for 50 years before it dies. The thought that a dose of chemotherapy is suddenly going to kill it, it's a pretty quiescent cell. It really should be quite tough. Granulosa cells, though, are not. And so it may be that the defect here is depleting the granulosa cells. And so it could be that if you repopulate the granulosa cell population of the ovary, that may actually rescue a lot of the oocytes. So this is, again, just looking at the steroidogenic, just from the blood of the mice. So if we look at the mice that got chemo, their estradiol levels fall precipitously, whereas we see that the mice that got the sorted cells, their estradiol levels go up. Their testosterone and progesterone levels don't go up. So these are estrogen preferencing producing cells. And then this is where things got really fun is, okay, you have neomutagenesis. So then we looked at, since these were injected into the ovary, we questioned whether or not the mice could spontaneously conceive. And they could, just spontaneously breeding. So we had day 18 embryos. We saw green embryos. When we took out ovaries from the mice, we could see green eggs in situ, and then they would have live pups. Now,
How do you know that this is neomutagenesis and not just retained primordial?
so we had to do maternity tests. So what we found actually was if you just look at the GFP, some of them are GFP positive and some of them are GFP negative. Some of them are retained oocytes, some of them are derived from the ones you injected. And we only injected one ovary.
Okay.
So what we would see is the other ovary, there were paracrine effects. You actually had retention of oocytes in the ovary that we didn't inject, as well as the one that we did. And we did, for each mouse, we did lineage tracing using SCR testing, just like you're on CSI, to figure out which pups were derived from the stem cells and which ones were native, right? Because the stem cell derived mice were different buffer, like a donor egg, essentially. And so this is showing several different litters of these mice. So the open arrows are GFP negative pups, and all the other ones are GFP positive pups, which is fun. So we would see these litters of, and they would be mixed. Some of them were oocyte derived, and some of them weren't. And phenotypically, they looked identical. Now then we questioned, well, what would happen to these pups? So we bred them to the F1 generation and the F2 generation. We found that the pups were fertile, and their offspring also were fertile and seemed to be normal. So they had normal litter sizes and seemed to have normal fertility. So the take-home idea here is, could this be an autologous stem cell-based model for fertility endocrine restoration? And that, can you take granulosa cells, ideally autologously, although I can't think of any reason actually why you couldn't have granulosa cell donation, generate them into iPSCs, and now you would have a stem cell that, when injected into the ovary, and I think this is, we were talking about John's work before, this is, I think, one of the key things. It's putting these cells into the ovarian stroma is quite key to get them to differentiate in a native way into both oocytes as well as granulosa cells. You could either create a system where you ex vivo are generating bioidentical hormones, or are you actually repopulating the ovary itself with a cell-based therapy?
You would be, if you use donor granulosa cells, you would be populating with donor genetics, right?
Well, maybe not, because it'd be probably a chimera.
I mean, if you get the granulosa cells salvaging them.
Correct. So because you could sort them for the ones that are steroidogenic, but not won't make germ cells.
Yeah.
So you could do that too. So just to wrap up, we know that chemotherapy induced ovarian insufficiency is a large and growing public health burden. Granulosa cells are really a promising source to induce pluripotent stem cells that I would argue are uniquely positioned for this problem, much more than the idea of making iPSCs for fibroblasts or stem cells or things like that. And what's quite fascinating about granulosa cells is not only are you recapitulating the endocrine functions, you're recapitulating the reproductive functions of the ovary as well. And maybe this is a way to rescue oocytes from atresia. So obviously I want to thank Ray. This was really Ray's insight and genius which led to this, and the people in Ray's lab over the years who did mention his work, people from my own laboratory. My laboratory tended to handle the chemo and the animal work, and then other supporters from the RAI division. The great most support being Mark Hornstein and Liz Ginsburg, who were great friends and mentors and advocates for this work. Thank you.
Questions? David?
Yeah, thanks. That was a great topic. In terms of the breadth too, in terms of the magnitude of the problem. Granulosa cells, there's a big difference between a murogranulosa cell and a cumulus granulosa cell. And, I really like the logic of let's try to go back to a not so differentiated state in terms of generating those lines initially. I'm not sure how many people are aware of it, but back in the days of somatic cell nuclear transfer, i.e. cloning, the most efficient cell to reprogram is a cumulus granulosa cell. Not only that, cumulus granulosa, and this work, Jonathan Verclum showed this in human cumulus cells, they have totipotency. So under different conditions, they will form adipocytes, they will form smooth muscle, they can go pretty much down all three embryonic germ layers. So in your experiments, you showed us some green eggs and you showed us some green granulosa cells. I would have thought you would also see green vasculature, green interstitial tissue, and other things. Was there a little more expression of, say, different cell types, different somatic cell types?
So not if you sort them based on the AMH receptor. That's the key. So you're absolutely right. If you took unsorted stem cells, for them to drive granulosa cells, absolutely, you'll see adipocytes, you'll see vascular cells, you'll probably see all different differentiation. But if you allow them to do this little bit of spontaneous differentiation in vitro, and then you sort them based on those receptors, now they won't do that. Now they will only go down these ovarian differentiation pathway. And for whatever reason, and I can't explain exactly what it is in the follicular fluid, if you spike a little follicular fluid in there, it sort of nudges them in the right direction. Which is actually a technique that we've adapted in my own lab for other stem cell experiments, right? If you want to make a cardiac cell, well, take some cultured media from cardiac myocytes and spike that into your culture, and maybe the stem cells move that way. So it's there could be something that is universal in that.
The mice that you were working with were all had induced ovarian insufficiency because of chemotherapy, because that's what you're interested in.
Right.
Did Ray ever try this on senescent mice?
We never tried on senescent mice. What I will say about nude mice, though, is that nude mice do. So we did do it in nude mice just without chemo, and it works there as well because they do have accelerated follicular atresia, a mechanism that's not quite clear what that is, but it is a function of nude mice that do that.
I was interested when you kind of mentioned that perhaps the oocytes are not aging, but the granulosa cells are aging, because that goes in line with what we've been kind of hypothesizing
Yeah,
for about 15 years. Yeah.
Some other data on that. There has been some data that the oocyte itself really doesn't get, I think you mentioned that, damaged by chemo. It is, once it's getting recruited and starts its journey through the microenvironment of the ovary, that it gets damaged.
So our hypothesis been if we could do something to improve the ovarian environment, we could possibly make better eggs.
Right. So I would say from a prep, obviously there's a lot of concerns about fertilizing induced pluripotent stem cells to make humans.
Sure.
But it could be that that's not the process you actually need. It could be that really what you need to do is supplement an ovary with granulosa cells, and the ovary may repair itself.
What do you think about the mitochondria? I mean, the nuclear transfer thing that we're trying to take the good mitochondria cytoplasm and then transfer it to another thing.
Perhaps we'll propose that, right? Can you take younger mitochondria and put them in?
Yeah.
It hasn't worked very well.
It may not be that that's really what the problem is.
Once you
It's not the oocyte, it's the support cells around the oocyte.
Yes. Yes.
Once you resuscitate the ovaries somehow, it's going to make its mitochondria.
That's true. Right. So it may not really be that the issue is aged oocytes at all. It might just be the fact that there's a natural granulosa cell decline. Senescent granulosa cells.
It's all in the microenvironment. I mean, in cancer, it's not different. I mean, that's now being recognized more and more importantly that it's the microenvironment that is really determining the fate of what is happening. So if we can get rid of the fibrosis, for example, and get some new granulosa cells in there.
Well, I think that's been one of the ideas, just coming back to the beginning of your talk. You said this is work that came out of Carla Hutt's lab. You mentioned Amy Venture.
Right.
Whether it's chemo or even they've done some work with radiation exposed ovaries as well. And there is a baseline level of DNA repair going on in even primordial oocytes. Okay. And of course, you boost it, but it's, there's much more damage in the granulosa cells, especially of antral follicles, okay, which are in a more proliferative state. So you can kind of expect that their cell cycle's moving so fast, they're going to be more susceptible to it. And that's kind of where the burnout hypothesis came from, which, by the way, is what Joramiro was suggesting, that early follicle pool, which is making the AMH, is what was suppressing primordial follicle activation.
Right.
So I don't know where that story has gone, but is there a third kind of model for the reason for the POI?
Well, that's part of what I'm proposing, is I think there may be a granulosa cell centric.
Granulosa, maybe some kind of ovarian stem cell that you need to kind of keep the niche going.
Right. And that the idea would be if you could maintain that microenvironment, then the oocytes would be fine. In other words, perhaps what you need to do, so again, there's a window of opportunity. So again, most of these patients are not going to have POI immediately after completing chemotherapy.
Right.
As I said, it's usually a year, 2 years, 3 years lag. So what I propose is to say, well, no, what you really want to do is when someone completes chemotherapy, you know that she's at a high risk of developing POI, you infuse the granulosa cells into the ovary at that time, before the POI is fully developed, and then you'll prevent it from developing. In other words, it's a restoration or repair process. So if you intervene soon enough, then you won't get the follicular atresia.
Stay ahead of the game.
With
Right,
cancer,
yeah.
cancer patients, you have the opportunity to harvest granulosa cells before they get their chemo. I mean,
Even for the chemo, but even if you did it after they got their chemo,
Yeah.
right? So in other words, because you probably have a year or
you
two
can
window
have
there.
that honeymoon time.
Right, where you could rescue those oocytes. So I would argue those oocytes haven't been damaged by the chemo, the follicular atresia is happening
That has
from
been
this
shown.
process.
That has been shown.
Well,
Fascinating that it's the AMHR2 cells.
Yeah,
that are-
exactly.
Yeah,
Mhm.
right.
What is that all about?
Yeah, well.
That's the big question
Yeah.
since I discovered the story with all those receptors in the adrenal.
Yeah.
Why the hell are they there?
Right.
You know?
So are they similar origins? I mean, embryo.
Yeah, they have
embryonic-
adrenal and ovaries have a common primordial in the embryo.
Yeah.
So, and there have been experiments where people have induced follicle production in adrenals.
You can get germ cells in adrenal glands, for sure.
In
Yeah, I mean, germ cell
Yeah,
tumors.
yeah. So it's, they basically come from the same stem cell. So there's still a lot to be learned, but it's also not surprising that the oocyte is not damaged, because when you think about it, how primitive the primordial follicle is, it has basically no supply. It's incomplete. It exists for years and years in complete isolation, more or less, with minimal energy need and nothing going on, until it gets activated.
Well, and one of the other things that makes the idea of sort of granulosa cell donation and granulosa cell transplant sort of interesting. We're talking about autologous granulosa cells, but the ovary being an immune privileged site, you can imagine that if you inject granulosa cells, even from another individual, it might not be rejected.
Yeah.
Yeah.
At least not very easily.
Yeah.
So I again, there's a good argument to say that it might be taken up very well by the ovary. That experimental, that at least in the now these mice are immunosuppressed mice, but even in mice that aren't immunosuppressed, they will take them, unrelated donors.
Was there any particular reason you went with the nude mice? I mean, a lot of the other work in this field has been with like Black 6 and,
So the donor mice are Black 6, right? But we use nude mice for two reasons. One, we really didn't know if they would reject the cells or not. That was one question. But also because we knew they would be easier to induce follicular atresia because they have this accelerated follicular atresia anyway, they're predisposed to it. So the argument that we made was that this is a better model of, say, BRCA1 carriers, right? Sort of a similar problem, and accelerated follicular atresia.
or outbreak, which probably,
Exactly right.
you might not have seen that result in an outbreak.
That's true.
Let me ask a clinical question to all the brains here. Can we, based on how much AMH is being done on everybody who shows up, I would say the 20 patients, 10 ask for an AMH because they're trying to freeze eggs. Can we predict who is going to have follicular atresia based on the level of AMH?
I'm not the one to ask.
Predict when and where.
When they're going to lose. I mean, many of them, the AMH is low and they're 30.
It hasn't proven to be very.
In
You
my
cannot
experience, it hasn't, but
You cannot predict menopause based on AMH very reliably. I mean, it's a general trend, obviously, but you cannot predict it really with sufficient accuracy. But
The AMH that you're measuring is just a reflection of how many antral follicles
exactly.
are there.
I'll tell
and
you.
the other things will influence how many antral follicles will show up at a particular time. So it's not a constant indicator. Over time, obviously, people become menopausal or have no AMH, but it's not a good way of telling the future.
I will tell you, most gynecologists right now offer AMH or test AMH, or not everybody.
And it's an indirect measure of somebody's
And
potential of
it is
responding
low.
today.
And they
But-
send her to me to figure out what that's going on. And my typical lecture is, we cannot predict this, we can't tell this, we can't tell that. But does anybody know if there is any literature indicating that this woman is going to go into menopause in 5 years and will not going to have eggs?
Yeah, there's a lot of literature,
Yeah.
but it shows what was said here, that it is not a real good predictor, even though recently I saw a paper somewhere where they actually built a better model in some ways in predicting the age of menopause. But in principle, it is not a great model. At the same time, AMH, especially in older women, is clinically, I think, the best predictor. I mean, that, in an older woman, I take the AMH value any day ahead of the FSH. In younger women, I take the FSH as a predictor for their current status. Neither tells me when this woman will go into menopause, because there are lots of reasons why women can go into menopause.
These women are trying to plan egg freezing.
Yeah.
That's why I say, that's why there's being screened.
For egg freezing, again, it depends on the age, but if they're young, I think the FSH is to a degree more important than the AMH.
If you have a 23-year-old who has an AMH of 1.2, yeah, probably she wants to freeze some eggs.
Yeah.
0.5 is what I'm saying.
Yeah, that's a problem.
Yeah.
She probably won't make it to 50.
I don't think she'll make it
That's
to
for
40.
sure.
But you can't predict when she's going to come in.
Yeah, but the other side of the coin is that even if you take young women who are diagnosed with premature ovarian aging based on low AMH and or high FSH levels, that fact by itself does not predict that they necessarily will have early menopause. They may still have menopause at age 51.
And the other thing is you're dealing with young people who might be using contraception, and long
Yeah.
as contraception can lower your AMH.
Yeah, so does IUD,
Right.
but so does IUD, but in absence of those, I mean, given how, is this the granulosa cell dysfunction in these women?
Maybe, ideally, what you would have is a marker of the granulosa cell health. That's really what you want. I mean, that's sort of what you're getting with AMH, but interesting to know. I don't know if there's
Because
a way.
I'm
You
just
could-
wondering.
I mean, what I would predict would be if you could measure their granulosa cell pool, that would probably just give you more information.
That's why I saw yesterday a patient who has been for 20 years on birth control pill and has no AMH and has been told for 15 years that she's in menopause.
So who's carrying the ball for this now? Are you still doing this, or?
Well, I'd like to take this work forward in my own lab. I mean, I'm still very interested in the topic, and again, I see these patients all the time in my own clinical practice. I will say I need fertility colleagues who want to provide granulosa cells. I'm not doing the IVF cycles, so
You must have somebody out there.
so there's
Yeah, there's some very good people.
there's people who are interested in the question, but I do think that part of it actually is more of how does this get translated actually clinically, right?
Yeah.
And again, the way that I see taking this forward clinically is to repopulate ovaries with granulosa cells that are steroidogenic, not the, ideally, you would want to focus probably at first on women who are more interested in the endocrine effects rather than the fertility effects,
Yes.
right? Just from a safety point of view.
So I can ask something, because we're hearing more and more often the concept of injecting stem cells into ovaries. A lot of IVF clinics maybe not in this country, but outside this country are doing it. Whenever we're using stem cells, there's always a danger of malignancy.
Absolutely.
The ovary is probably one of the organs with the highest risk of malignancy, if I had to guess.
Yes. I can tell you what happens if these experiments don't go well.
Okay, that's exactly the question.
Yes. So what happens if you don't sort the cells well?
Yeah.
What happens if you keep the cells in culture a little bit too long and they start to polarize in the wrong direction? You inject them into the ovaries of the mice. The mice develop malignancies, terrible malignancies very quickly. So there's definitely a safety issue there. Now, what I will say, I think the idea, this isn't just for ovaries. I mean, we see stem cell therapies being purported for every condition under the sun. I think indiscriminately injecting stem cells and assuming that they're going to magically repopulate whatever you want to repopulate is probably fanciful. It might occasionally happen by chance. I think the key is if you can identify a population that is differentiated in the direction that you want and use that, you have to have someone selecting out the stem cells. So I think the idea of injecting either just embryonic stem cells and expecting them to magically fix a problem, or
Even mesenchymal
or even iPSCs that haven't been. So I would worry, and we see this. I mean, so a huge tumor on the thigh of a mouse. If you take unsorted induced pluripotent stem cells and you inject them into an organ, they will form tumors, I mean, by definition. So I think that it has to be a sorted
How do
cell.
you get this past an RFP?
Well, I think you could show, again, I think if you focus on the steroidogenic cell population, I think that would be key. You would have to have a mechanism of monitoring the ovaries very closely. I think, again, that's why I would prefer to focus on women who were, say, in their late 30s, early 40s with ovarian insufficiency and wanting to not have to take 10, 15 years of hormone replacement therapy. Look at that. I mean, your safety mechanism there is the fact that, you know, if they start to develop a tumor in the ovary, then you can take it out. You know, the good news is that probably is going to be a germ cell tumor, not an epithelial tumor, at least. But, you know, that would be the safety concern.
Have you ever, sorry,
Go ahead.
have you ever tried to make parallelisms or maybe, pull some data comparing this technique or like this potential technique with the actual ovarian tissue transplants that many times are done after chemo as well, and sometimes are done actually fairly fast, they don't always wait 10 or 15 years of this transplant, sometimes are done 2 years after chemo, and of course we see most of the times the good endocrine restoration in most of the cases, at least for 2 or 3 years, usually. Sometimes for fairly more than that, and always every time we see that the AMH goes up and that they are actually start ovulating, we always assume that it's from the oocytes that we transplant that in the tissue. But I was thinking now maybe also the granulosa cells that you transplanted and that actually grafted on the cortex of the ovary also helped other eggs that were there as well, right? We always just assume that those are the eggs that we are putting back, but maybe. Maybe there's more than that. I was just thinking all the time about that.
Yeah, that's a good point. It could be it's the granulosa cells you're transplanting. It would be if you had a way of labeling the tissue that you put back in to see which oocytes you had afterwards.
Yeah.
Again, if you had a sort of a donor scenario, you could probably do that.
Yeah,
So you
of
can
course,
imagine-
mostly it's an autologous always, no? And I was just thinking if retrospectively there will be any way to actually test that, like with all the data that we have just now retrospectively, but I don't think that would be possible. Because how do you differentiate that, But like I just have this hypothesis now, it's very plausible, no?
It's absolutely possible, yeah. So I don't know. It also, one thing that's, I guess, intriguing about this particular approach as opposed to cryopreserved tissue is that theoretically this is not a limited supply. You could keep
Yeah.
You might have to reinfuse them every couple of years. It's possible, but you could also just thaw them out and put them back in. Whereas the ovarian tissue, it lasts for 2 to 3 years typically, and then depletes itself. Or the idea that if you could find a way to safely keep these in culture, it might be a way to not even have to have an autologous infusion.
Yeah, I mean, one of the main issues that with the transplant, right, is like, we know that like 60% of the tissue that you're transplanting, it's gonna die pretty quickly within the first 48 hours because of ischemia. So I don't know if, because you were thinking about the clinical application, right, of these stem cells, how would you graft them actually?
So we just inject them directly into the ovarian stroma.
Similar to what we do with like the PRP, similar situation, like a little gel that you would inject literally in the stroma? Yeah, interesting.
I mean, you could inject it either laparoscopically or transvaginally, depending on how you access the ovary.
Yeah,
Yeah, one problem is if it's an ovary, it's just hard to get to if it's a tiny ovary.
David, isn't the company that you are an advisor, aren't they commercially exploring that?
Comida?
What's the name of the company in New York?
Comida. It's one of their product ideas. Right now, they're mainly working on commercializing IPM, in vitro maturation of oocytes, using the stem cell lines that came from George's lab, not these. So there are lines, and they're very similar. Their eLife paper took a very similar kind of course that you all did in terms of making iPS cells and then sorting them for different properties, including steroidogenesis, including expression of germ cell markers, blah, blah, blah. And so their main product line right now is they want to do low stimulation, low or no stimulation, collect cumulus complexes, and then they get co-cultured with the stem cell lines that do happen to be active steroidogenically. And the idea is they're producing factors that are going to improve cytoplasmic quality in the egg. But they have other ideas for kind of using, moving these iPS cell lines down different lineages for not just ovarian restoration, but other female reproductive tract tissues.
Okay,
thank you so much.
thank you.
Yeah,
Thank
yeah.
you very much.
No questions.
Okay, and we're even on time.